Hello, 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 hello. Good evening, everyone, and welcome back to the show. I always have fun when I play that song. It makes me think about being on the beach. Well, welcome to our show. Hopefully, you had a great Monday and a great weekend. This is Dr. Dwayne Wood. If you're new to the show, we welcome you and we want you to enjoy what we're doing tonight. Tonight, we're talking about health disparities, so minority health disparities. And we've got a wonderful guest who is going to be talking with us tonight to help us discuss this very, very important topic. If you are new, I am Dr. Dwayne Wood. That's Wood with an E. The E stands for endocrinology. Here on our channel, we help to educate, we help to empower, and we help to encourage you to take charge of your life and your health, going to that next level, avoiding complications, and living the life that you've always wanted. If you are new, also put that in the comments because we'd love to give you a little hand clap, let you know that we are excited that you're here and welcome you to our community. As we go throughout the evening, if you have questions that you would like to ask, make sure you put those in the chat and put a Q in front of the question so that I know that you are, that is a question that we should get to. So just very excited. We had a great week so far. So Monday was actually pretty good. Mondays are good for me because I'm always anticipating getting on the show and talking with you. If you are here, if you're watching right now, go ahead and give us a thumbs up, give us a like, share this with your friends. If you got folks that are out there, let them know that we are on. Take copy that link and send it to your Facebook, Instagram, Twitter, whatever platform you're on. You can actually find us as well on those social media platforms. So we've got LinkedIn, Twitter, Buy Me a Coffee. So all of those places you can go ahead and find us, and that is Dwayne Wood MD. So Dwayne Wood MD. Glad that you, if you've not already done so, go ahead and subscribe to our channel. So, as you see, I always do a shout out at the beginning of the show. And tonight I am shouting out the Light Away. As you know, we have two medical practices. One is a traditional endocrinology practice, and the other is a weight management program that's run by Dr. Charmaine Wood, who's been a guest here on our show. And the practice that does the weight management is the Light Away. And so tonight I'm wearing the Light Away shirt. So thelightaway.com. So if you are struggling, you think you are stuck, this is a great place for you to get some help. So the Light Away. You know, health disparities. So disparities, you know, we talk about this kind of, you know, on the back burner. You know, we mention it, but tonight we're going to put it front and center, and we've got an awesome person who is going to be discussing that with us tonight. That's Dr. Obinna Oriaku, right? So he is known as Dr. O. He has a medical practice out in Charlotte, North Carolina, and he also is so interested in providing healthcare that he has founded a platform for delivering healthcare to sub-Saharan Africa, and developed an interest in helping people develop and get equity within healthcare. And so we're going to go ahead and bring him up on right now. Dr. Oriaku, we are so glad that you are here to join us. Thanks for joining us tonight.
Thanks for having me, Dr. Wood. It's an honor and a pleasure to be here to share the screen with you. By the way, I'm a huge fan of yours. I love the work you're doing, and I am just happy to be here.
Oh, well, we're glad. We're glad that you are here as well. You know, we met each other, and I'll tell you, when I saw your first show, I said, okay, this guy is going somewhere. So I've got to make sure that I get connected with him so I can hold on to him as he rises. So I'm
You,
glad that you are here.
you are too kind, Dr. Wood. You are way too kind. Listen, I'm a huge fan, and listen, thank you for embracing me as a brother. The work that we do sometimes, and I'm new to the space of broadcasting the work that I do. But there comes a time when you want to make impact beyond the patient bedside. And I thank you for having embraced me. We've talked quite a bit off the screen and personal matters. helping me with my technology challenges, being the pro that you are. And it's amazing the interest that we share in the common interest we share in healthcare. For me specifically, my interest in health disparities and minority population. That has always been my thing, and I didn't come to it by accident, really. So, and of course, we'll get into some of that. But yes, I'm happy to be here. I'm glad to be sharing this screen with you, and I'm glad that we're speaking about a topic I am passionate about.
Awesome, awesome, awesome. So why don't we do this? Why don't you take a minute or so and tell our folks who you are and where you're located? We'll give you a chance later on in the show to kind of do a little plug for what you do, but just tell us who you are and just introduce yourself.
Okay, and it's going to be in two parts. Who I am, I'm Dr. Oriaku. That's an African name, right? Most of my American patients can't manage Oriaku, so I have adopted the Dr. O moniker, and I wear it like a proud badge. So, Dr. O, I'm the founder and CEO of Crown Clinic PA, an internal medicine practice here in Charlotte, North Carolina. We've been in practice now 19 years to be exact. It's been an exciting journey, and my majority of my population are minority population. Well, I'm in an urban area and all of that. So that's as far as practice. But how did I get into this, and why is this near and dear to my heart? Just briefly, right? So I was born in Nigeria. I grew up in rural Nigeria, right? This was many years ago. I'm not going to tell you how old I am right now, but when I was a child, I was 5 years old, and I started having difficulty breathing. I just couldn't catch a breath. My parents were scared; they didn't know what was wrong with me. I didn't get a diagnosis of asthma. Get this, until I was 10 years old. I did not get a diagnosis of asthma. And when I was 13 years old, I almost died from a bad asthma attack overnight. I mean, I tell this story over and over, right? Kids, babies, when the nighttime comes or when their parents want to put them to sleep, and they're scared of going to bed because they're scared of the boogeyman under the bed. In my case, I was never scared of any boogeyman under the bed because there was no boogeyman under the bed. My boogeyman was my asthma that would descend on me with increased symptoms through the overnight hours. So for people that don't know, in childhood asthma, your symptoms are almost always predominantly overnight hours. It might start during the day, but it worsens overnight. So I was always afraid I couldn't get my next breath. I was always afraid I wouldn't wake up the next morning to see the light of a new day. That was how I spent my childhood. It wasn't until at age 15 that I had my first asthma pump. And at age 13, when I almost died from asthma, I promised that if I ever made it to adulthood, I will be a doctor to give back. So I didn't come to the subject matter, the topic of health disparity and health equity by accident. This is my lived experience, and it's been my life's passion.
Oh, wow, wow, wow. That's amazing. I can hear the passion as you even tell that story. That's amazing. And, passion really drives what we do so much. So I'm not happy that you had that experience, but I think it really has helped you develop into this area. And like I said, I can hear it as you're even describing it now.
It still is, honestly speaking, almost like a PTSD reaction for me. Talking about asthma and talking about my childhood experiences with asthma. Even in my practice, even though I'm trained in internal medicine, I run a family practice here in Charlotte, right? I see the whole family, all ages. A mother coming to me with a child with uncontrolled asthma takes me all the way back to my childhood, and I don't let go until I've given that mother and that child the relief that they need. Wow. That has followed me all through life.
Wow, wow, wow. Okay. Well, so let's just jump right into our topic for tonight with that as a backdrop. So let me tease out a little bit more though. So you said that you come to kind of being a physician and caring and having empathy through your experiences as a child with asthma, growing and so forth. What made you have a special interest in minority health and specifically disparities. We'll describe disparities here in a minute. But what brought you to this area?
That's an excellent question, Dr. Wood. So let's think. Let me put it in very stark details, so both you and people listening will understand. Um, it is a privilege that I'm sitting here talking to you today, because I could have been another dead child in Africa that parents didn't know what caused his death, what the cause of death was. Right? I was 5 years old when I started to develop asthma symptoms. I was 10 years old before I got diagnosed with asthma. I had a near death experience at age 13. I didn't get my first asthma pump until age 15. So when you think about it, what else is health disparity? I lived health disparity. I'm
Mm.
here today, a well trained and reasonably accomplished physician, right? But I could have died in my childhood because I didn't have access to care, because of where I was born, where I lived, and so on, and who my parents were. Because right at that time, make no mistake about it, there were other children that lived in bigger cities than where I grew up, that had access to whatever the best care was at that time in Nigeria, and they could get the medications that they needed, and so on and so forth. Some of my classmates in medical school grew up abroad and grew up in England and America, and they had access to care as much as was available in those days. But I could have died in childhood at age 13. So health disparity is my lived experience. It's not an academic exercise for me.
Hmm.
And when I came to medicine, that has always been what drives me.
Wow, wow.
I
Well,
still get emotional talking about it.
I hear it, and why don't we do this? Give me a definition of health disparities.
I will be glad to do that. And so that before I put the Dr. O spin on it, let me give you the CDC definition of health disparity. And I'm just going to read it verbatim so I don't dilute the message. The CDC defines health disparity as preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged, racial, ethnic, and other population groups and communities. That's the
Mm,
CDC definition of health disparity.
right. Well, so as we get into the conversation, let me also throw in and if you would give me a because I hear this other term, right? So we've got disparities. We also have health equity. How do you define health equity?
Okay. Again, I will borrow from the CDC. Health equity is a state in which everyone has a fair and just opportunity to attain their highest level of health. A state where everyone has a fair and just opportunity to attain their highest level of health. And they go on to say that achieving this requires ongoing societal efforts to address historical and contemporary injustices, overcoming economic, social, and other obstacles to health and healthcare.
Wow, wow, that's a mouthful right there.
Absolutely. And this can be passed in all kinds of ways. And by the time you begin to tear it apart, you peel the onion layers, you begin to understand that. And it is very glaring. We'll get into some of the details. It's very glaring, the differences in outcomes in healthcare between minority population and the rest of the population. And some
Right.
of that is based on disparity and inequity.
Okay. So why are there disparities? I mean, you talked about growing up and having other people have access to other things. Is this a because when I hear disparity, when most people hear disparity, I think they think that it is a conscious thought that someone says this population I'm going to not give them access. Is that how a disparity happens?
No, actually, that's not it. Now, I don't have any data to support this here, but I'm just going to say, just from observation, I don't believe that a majority of health disparity is a deliberate me discriminate against you, Dr. Wood, because your beard is longer than mine, and you look more distinguished with your with your salt and pepper beard. It's not that. That's some of it. Now let's not make any mistakes about it. That's some of it. But actually, there are all kinds of things that is ingrained in the system through the years that make people not be aware that that disparity occurs, right? And when you're not aware of these little systemic differences, you might not it might not be upfront to you. And then, of course, there's the other one that is a bias, right? You already you're looking at me now. You form your opinions of what you think I am and who you think I am. But if I came dressed a different way or look a different way, that opinion changes rapidly if you never met me before. So some of those biases do exist. But back to your question, what causes disparities? A lot of it is historical, right? A lot of it is socio-economic. A great big example is the lack of access. I'll take the African American population, for instance. Disparity by no means does not only exist in the African American community, it's actually very common in all kinds of minority populations, however, you dice up minority populations. But I'm going to use the community that I'm part of and that I'm familiar with. In the African American community, years back in the day, right, a black man or black woman wouldn't go to the main hospital in town to get care, right? Because there was, in the South, there was Jim Crow, there was segregation, and all of that. And even for the well meaning doctors that practice in that age, if you never saw a black person, if you never attended to a black person, you wouldn't understand both the cultural nuances of their presentation and other things, and also the trust, either you trusting the patient or the patient trusting you, the non-minority doctor. So those things, and then of course, communication, language, right?
Mm.
I'm speaking to you with an African accent. uh, People come up to me, oh, I love your accent. I'm like, I'm glad you do. That's the only accent I have. it's not like it's not like I can switch it out tomorrow for something else. But so I'm speaking with you right now clearly enough in my head, but some people might come across my accent and have difficulty making out some of the words I say or the meanings behind the words I say. So these little things can contribute to disparity, but of course, the major component also is socio-economic: lack of access to care, not having insurance, not having good enough insurance, and particularly with the minority population and the rural population. Let's not forget, with government-sponsored insurance, you some specialist practices may not accept your insurance, and you're left to fend for yourself. All those things contribute to the systemic problem that is health disparity.
Right, right. Wow. Now, one that I think I want to jump on is this idea of language, right? So as an endocrinologist, there are several things that I do with patients that I think are pretty common and easy for people to understand. But there are also several disease processes that can be complicated. So there are times where I have someone who comes to the office and we get a translator. And the reason I get a translator is because I don't think that even if they bring a family member who's non-medical, that family member can necessarily explain some of the technical details that I'm trying to get across.
Absolutely.
But there have been times where someone shows up in the office without a translator,
Yep.
or we see them at the hospital or wherever we may encounter them.
Yep.
And even that difference, right? If I'm trying to explain something and they're not getting it, not because there was a systemic problem, but we just have difficulty communicating.
100%. Absolutely. Now, remember, some words don't translate directly to a different language, right? Some English words don't have a representation in whatever other language you're trying to translate it to. So it takes somebody that understands the context to be able to translate accurately what information you're trying to put across. And let me take that even further. When I travel out of the country, when I travel to non-English speaking parts of the world, right, I
Mhm.
am reduced to almost being mute. I go shopping, all I do is point out, oh, I want this and I want that, because I can't express myself in whatever language. And unless I have somebody, for instance, if I had a friend that lived in a foreign country that I was visiting that could help me translate. But otherwise, in these days, well, thankfully these days I have Google Translate on my phone, and I'll try to quickly punch in a word or two. But back in the day, you didn't have that. So that's almost a minor laughable component to that. But language barrier, if I can't tell you what I'm feeling, how can you as a physician be able to treat me correctly? Because somewhere the information is lost in translation. You perceive what I'm saying wrongly, and for that matter, me as a patient, I perceive your intentions wrongly as well, because that communication did not exist. And
Okay.
quite hospitals and medical practices now, it has become more common to have a translator service on hand to be able to help bridge these communication gaps.
Right, right. Now we'll come and we'll talk a little bit more about the systemic things, but can you tell me how, aside from language, are there any are there any effects of cultural norms, so things that are in a culture that can lead to disparities?
Absolutely. That is a huge one, Dr. Wood. Now, the American society is such that, your personal voice is recognized. Your personal voice is recognized, and it doesn't matter who you are, it doesn't matter where you're from. You know and you understand that you deserve to be heard, and you let people know that. But there are quite a few immigrants in my patient population, and there are other international people that I interact with, where almost as if the doctor image, the doctor figure, is such a figure of authority that is almost perceived as disrespectful to ask questions or to push back or to give a different opinion. And I and then also other cultures where and this happens quite a bit in my practice. A husband and wife team comes to me, and is the wife's visit, but it's the husband that does all the talking, and the wife is an adult sitting there by my side, and so these are things because I'm culturally aware of these differences. I It's easy for me to accommodate, because remember, being an immigrant to this country as well, I've lived here more than 3 decades now. However, I remember my initial days of getting here, how difficult it was for me to understand how to interact, understand the right context to interact with my peers. So, having lived that, again, another lived experience, it's easy for me to accommodate this within my patient bedside. But blow that out to the topic of health disparity. That's what we're talking about, right? Raising the consciousness, the awareness that, hey, Dr. Wood, because you speak perfect English, this other gentleman that doesn't speak as good as English as you do, it doesn't mean that they are illiterate or not smart. It just means they have a language barrier. And if you are not in yourself internally aware that that language barrier exists, then you may not be the best doctor you could be to this patient, even when you didn't mean to be mean or to be less than perfect for the patient.
Right, right. Wow. So let's move on and let's talk a little bit about some of the systemic things that may be out there. I know one of the things that for instance, in my area, there are several studies that were done, or several treatments that I practice, that were not studied in certain populations. They were really
100%.
extrapolated from the majority population, and we use those treatment modalities now. Is that a place where we can have some trouble?
Absolutely, Dr. Wood. This is a very important topic actually to bring up right now. And there are people that have been pushing for inclusivity in ethnic minorities when it comes to research, when it comes to studies, because traditionally it has always been you have thousands of people sign up for a study and very minuscule minority representation. I'll give you a startling example that is in the news right now. I don't know, you may have heard of this, but this is one of the more recent ones. The pulse oximeter that we use, this came to the fore because of the COVID-19 pandemic we've all been going through 2+ years now. Pulse oximeters, we just realized recently that pulse oximeters are not nearly as accurate in people with darker skin. Now, think about that. If the pulse oximeter, listen, I'm a physician, right? The tools I use, I believe they're accurate, right? And you, Dr. Wood, comes in. No, let's not just call it, let's not even think you are Dr. Wood. Mr. Smith walks up from the street. You come into my office and I check your pulse oximeter and it's giving me a falsely decent reading. And there you are dying of COVID. I don't realize that your oxygen saturation is falling low enough, and I don't take the necessary action to save your life, Mr. Smith from the hood, right? It- how am I? Listen, by the way, to just be clear, right? Let's just say, of course, I'm a black doctor and you're a black patient, and I'm trusting my equipment to give me the correct reading, and I don't realize you're hypoxic, which is when your blood oxygen level falls below a critical level. I won't give you the right treatment that you need. So that just came to light in this past 2 years, all of us fighting COVID, because the calibrations and the science that went into pulse oximetry did not include enough people of dark skin tone to compensate for that difference. Here's one more example. In nephrology, you're an endocrinologist, I know, and your best friends, the nephrologist next door. There's a calculation we use for renal function, for your kidney function. When I'm looking at, again, Mr. Wood from the hood, when I'm looking at your kidney function, trying to determine, is this kidney function bad enough to require dialysis or to begin to talk about alternate therapies? There was a calculation for kidney function called the GFR that we use to measure and estimate function. Again, when the GFR number they came up with it, there weren't enough African Americans in that study. So what did we do? We came up with an EGFR, which is an extrapolation of the GFR. Well, if you're African American, we use the EGFR to calculate your kidney function because that will reflect more what your kidneys are doing. But that was a mathematical equation and calculation. It wasn't real study in the field, lining up a bunch of minority folks, African American folks, and say, come, let's measure your actual kidney function scientifically over a period of time to see what's going on with it. Again, this is one more example that representation matters because enough of minority populations were not included in this study. The wrong uh, conclusions were made and the wrong assumptions were made. And you and I, being African American ourselves, we adopted the same data to treat our patients,
Yeah,
not knowing that we are doing them harm.
yeah, 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 yeah. Now, one interesting one for me as an endocrinologist is that certain minority populations, certainly African Americans, tend to have a slightly higher A1C, just naturally. And so it is possible that there could be people who were diagnosed with diabetes that really didn't necessarily have diabetes. Okay. And so that is one that comes to mind. Now, sometimes we use that to say, oh, well, because I have a slightly higher, I don't need to do anything. That's not what we're saying at all. But just saying that there are certain differences among populations that can lead to treatment, under treatment, or sometimes even over treatment, where that can cause some issues. And that's really the
100%.
point of all of this, that yes, you can look at the studies, but sometimes the studies don't necessarily reflect the population that you're treating at the moment.
100%, which is a huge argument for inclusivity in studies because scientific design can, again, through bias, right, scientific design can skew almost against the minority population. So if you don't include enough statistically significant proportion of your study population to be from the minority groups, then your representation of facts will not include that group. And that's when we start making assumptions or doing mathematical calculations instead of going into the population and studying them directly.
Right, right. Wow. Well, tell me. So we've got these disparities. We know some of the possible causes of disparities, right? So whether it's cultural, whether it's language, whether not inclusive. Also, one that we didn't say, and you mentioned it at the beginning, socioeconomic, right? That's a huge one.
That's a
And
huge
and
one.
let's talk about the elephant right in the room. So we're in the era of COVID. And COVID-19, it exploded some of the differences in how minorities get access to healthcare. Can you talk a little bit about that?
Absolutely. It's one of those things, right? It was a collision of the worst of the elements in our healthcare system, where the minority population were more likely to be in the front line of service, right? In the service jobs, whether it's a bus driver or the grocery store clerk or the meat packing industry and all of that. And then they also had a higher burden of disease where, listen, traditionally people come into my office all the time. Their blood pressures are high, their diabetes is high, their asthma is not controlled, and they have come to accept that that is the norm for them. I have quite a few patients telling me, "Oh, I've always been this way, and my blood pressure never comes down." Now, when you have that situation, that's a powder keg, and then you throw in something like COVID-19, where think about this, Dr. Wood. What happened in COVID? The world shut down. People with the blue collar workers and executives, they sat in their rooms doing what we do now. We Zoom, we do remote work. The minority population, the African American population, most of our work was in face to face work, right? So you already have a high burden of disease. You already have those social determinants of healthcare that's working against you. And now you're exposed to a deadly, highly contagious virus. You had nowhere to run. You had nowhere to run. Because remember, at the very beginning, for people that wanted to underestimate the COVID-19 pandemic, they felt it was only for people with pre-existing conditions. Well, that was fairly abundant
Mm.
in minority populations. Where do we start? Obesity, right? Uncontrolled blood pressure, uncontrolled diabetes. I mean, seriously, kidney disease. These are all things that reduce your immunity and therefore make you that susceptible to COVID. So that when that fire hit the powder keg, boom.
Mm. Wow, wow. So they came with a burden already, and
Yes.
then now we just ignited it with COVID. And one thought. Okay, let's throw in, and among a lot of minority groups, there was this anti-vaxxing, right? That we saw for various reasons, and
And
so
guess where
that
that came
even
from?
compounded the issue.
And guess where that came from? We just described disparities. Those socio-economic and historical reference points, right? And now, remember, you and I have been doctors a while now. We remember how long it takes to develop vaccines, right? And how slow that process is, and how slowly you march through. Then all of a sudden, within 8 months, boom, there's a vaccine available. Boom, people get naturally suspicious. They didn't want to be in the front line. My own patients, even when I took my vaccine, I put a picture of it in my office. My patients were, "Doctor, oh, why would you do that? That you
Right.
don't trust the government?" I'm like, people are dying in droves from COVID. So yeah, historically, again, if you remember all the different bad episodes that's happened in the African American community historically, right? The syphilis experiments and what have you. People have ingrained distrust of the system, and that also contributes to health disparity. Because the very thing that can save you when it's finally done right, because historically the scars are still there, you're not trusting the system to come to your help.
Right, right. Wow, wow. Flashing forward a little bit in the conversation. So, what are some consequences, right, of these disparities? We've talked a little bit about COVID. Give us a kind of broader picture of what we are seeing or what's out there, because there are disparities.
Yeah. Where do I begin? Where do I begin? Let me. Here's one that is very near and dear to my heart. The healthcare statistics amongst Black men is so terrible across all parameters, right? Health outcomes. As Black men, we have the lowest life expectancy. We have the highest incidence of complications from diabetes and blood pressure. We have the highest complications when we end up on dialysis. We have the highest rate of complications. A lot of it also is because, especially with Black men, you come into the healthcare system a little late, you trust a little less, and you are less likely to comply with whatever instructions you are given, because there's all that ingrained distrust of the system. Let me put it a different way. You are married, I'm married, and I don't know if you have daughters. I don't have any daughters, but think about a young girl at age 9 or 10 or 11 when they start getting their menstrual cycle. From that early age, they have opportunity to interact with doctors from as early as 9, 10, 11. So going to the doctor for their menstrual complaints, for this and the other, all that is not that strange to them. And then a decade later, for those that wait that long, a decade later, you're having babies. Well, back in the olden days where you had your baby at home or in the farm, as the case may be, these days you go to the doctor, you have your babies, you have prenatal care. So the woman, generally, this is across board, the woman is more exposed to the healthcare system for a very long time. So it's not a difficult concept for them to go to the doctor to get the help they need. On the flip side, for the man, he's out there, he's bringing home the bacon, he's feeding the family, or what, or just being plain old macho, let's call it for what it is, right? Yes. Seriously, some of my friends have come to me saying how their friends were making fun of them for going to the doctor. Go figure, right? So there's that macho component of it. The male element will not go to the doctor, does not want to show weakness, and then you come to the doctor, you come into the health system a little late, and by then things have happened. So these are some of the real life costs of disparity. One more thing, leaving Black men alone. I have a study. Let me see if I can find that. This was a health North Carolina health equity study. It's a little dated, but I'll see if I can find both pregnancy outcomes, right, in women, child mortality rate, and maternity death rate. All these are more in African American women compared with their peers across other ethnic groups. So there's a real cost to healthcare disparity. There's real cost to not addressing these issues, because real human lives depend on it and health outcomes depend on it.
Wow, wow, wow. So listening to all of this, it can almost seem overwhelming, right? And I've had patients who've come to my office for whatever disease process, and it's almost like they've thrown their hands up. You ask them a question and say, I don't know, I just do what the doctor says. I don't know, this is not going to get better. I don't know, this is where I am. I don't know, right? So let's back up to kind of cultural things for a minute. So a diabetic walks into the office, and we talk to them about diet, exercise, managing their food. and we put in front of them a diagram of food that they don't eat in their culture.
Yeah.
Right?
Yeah.
And we tell them, okay, this is what you got to eat now. Right? So you take that 60-year-old man, the 50-year-old man, the 30-year-old guy even, and we say, okay, yeah, this is what you're going to do. And when they come back and you ask them, are you eating this list of foods? And say, no. We get upset because we say, you're not following my treatment plan. Talk a little bit about that for me.
Forgive me. Let me get a little lighthearted on this once. It can get heavy, and I will address what you said earlier on about being overwhelming. But just on this point alone, so here I was minding my business, growing up in Africa, and in the 80s, you remember the Jet magazine we would get maybe the 6-week-old, 2-month-old copies high school and college, and all these fancy pictures, glossy pictures of McDonald's burgers with the dripping. We didn't have that growing up in Africa in those days, and I couldn't wait to get to America to eat some burgers, right? Truly, right. True story. So here's where I'm going with that, right? I finally get to America many years later. It took all of 1 month, and I couldn't stand no disrespect to McDonald's, please. If anybody from McDonald's is listening, I'm not dissing the company. I'm just saying culturally, the uniqueness of the taste was gone after a few sessions. I'm like, okay, I'm going back to my fufu that I grew up on. So I bring that up to say what you're talking about. That is so very accurate, right? Again, talking about health disparity. You mean well, but you have to speak the patient's language. You can't bring a bunch of food and food diagrams and tell the patient, you do this, you do the other. How do they make it work? You have to be culturally aware, culturally attuned to say, okay, here's how I approach it in my practice. I give you an example. Say, these are proteins. These are vegetables. This is starch. Then I break it down and I give examples of what proteins are, obviously we know what vegetables are, and so on. I say, your dinner plate should be half vegetables, either raw or cooked. A quarter of it should be proteins, and a quarter of it should be starch. Now you go decide what starch you're going to eat or what protein you're going to eat. Then there are some very universal concepts like don't deep fry your food, right? Broil and grill and so on and so forth. So that's easy to communicate with the patient. But the lighthearted joke I made earlier, you couldn't get me to be on an American diet for any length of time. And I'm an educated, intelligent man, and I couldn't do it. My taste buds crave for the African food I was raised on. So if you, Dr. Woode, the expert, comes and you give me a chart of food and I don't recognize anything on it that I can eat, that's not going to last a week. That's not going to last a month. And I go back to my old ways. So that's actually a very important component of what we're talking about. Being culturally aware. Not being culturally aware contributes to healthcare disparity.
Wow. Now, I'll tell you, while you were talking there, I was jotting down because I'm going to use what you just said. I need a video to put out next week. I think I'm going to make a video on food, and I'm going to use what you just described.
I can give you a picture of my fufu dish.
Well, I'll tell you. So just funny. So I was talking to my sister, and we were talking about growing up. And there is a dish that we make in my culture that I haven't had for a while. And I'll tell you, she was describing it, and so I went out and I made some, right? And I made some, and that was last week. And within 2 or 3 days, it was done. And I went back to the store, bought more ingredients, and I made more. So I was trying to help my palate to become quote unquote what they say should be the better food, but my history and my everything in me said no. You need to have some of this.
Exactly. And honestly, there has been a philosophical shift, even generally in medicine as well.
Mhm.
I remember I went to medical school in Nigeria before I came abroad to do my specialty training. It would be you came to the doctor after you developed diabetes or high blood pressure, and we put out a list of all the things you couldn't eat.
Mm.
And it never worked. It
Right.
never worked. Listen, unless I had a gun to your head and say, if you touch it, I will shoot you in the head. As soon as I look away, you sneak a little bit. And that's just that's human nature.
Right.
So understanding how to make whatever is traditional to make it a little healthier. That's an easier sell. For instance, for the African. Let me just talk about my Nigerian diet, right? There's a lot of starch, fufu and rice and all of that. But what do? I overcompensate with the vegetable component. So I still cook my traditional food.
Mhm.
I still eat my wife cooks the traditional. I enjoy our home life. However, it's about portion control, right? I make a joke that I dish my meal the same way I prescribe medication. I almost measure it in grams and milligrams, right? Yeah, and it's one of the things I tell my patients. When you get to be an adult, food should be looked at as fuel. As yummy as it is, as delicious as it may be, food is just fuel. You never go to your car and fill the tank to overflowing because the gas smelled so good that day. No, you put in what you need, you shut your tank, and you get going because you need fuel in your car to operate your vehicle. And that
Right.
if I can get my patient to think of food the same way, begin to redirect and reappropriate our love for food. And that's one of those things, right? If you, Dr. Wood, came to me, you have an alcohol problem, you have a smoking problem, I would be on your behind to get to quit, right?
Right.
Stop drinking, stop smoking. How would I come to you and say stop eating? We can't stop eating. So
Right.
we have to devise a better way to make sure the communication gets better and people understand that we're doing this for your health. And no, Dr. Wood, I'm not trying to steal your joy, but I'm trying to keep you here long enough so we can rib each other every time we see each other.
There you go. Right. Wow. We've been talking. We didn't even take a break for station identification. So, hi, guys. Once again, this is Dr. Dwayne Wood. We're talking to Dr. O right now about healthcare disparities among minorities. If you're out there, if you've not already done so, please go ahead and subscribe to our YouTube channel. Share this with your friends. You see all of our social media platforms there. LinkedIn, TikTok. Of course, we are here every Monday night with exclusive health and wellness talk. And we're glad when you come and you join us. This is a great place for us to have our thought of the day. All right, all right. So tonight we're talking about enthusiasm. And let me read this for you. Enthusiasm is the best protection in any situation. Wholeheartedness is contagious. Give it to yourself and give it to others. Enthusiasm. I tell the story sometimes to our team at work that for a long time I woke up bubbly. So I got out of the bed and I was jumpy, and I'm one of those people when you roll over, right? Everything is bright. Everything is bright. And then I got to medical school and some other things started happening in residency. And I didn't wake up like that anymore, right? And life kind of got to me and I didn't wake up like that anymore. And I find that the times when I am deliberate about my enthusiasm, when I am deliberate about how I start my day, that my days go so much better. And so enthusiasm is one of the things that drives us, that drives our day to be the way we want it to be. Enthusiasm is protection for situations. Because when you're driving on the road, when you get to work and something happens, when somebody steps on your toes, somebody does something at work that you didn't like, that report that you've got to do that the boss didn't tell you that was due, the meeting that you've got to come and present at that you didn't know about, right? That fight or argument or discussion, if you will, that you have with that loved one that you didn't anticipate. All of those things have the potential for pulling you down. And enthusiasm, being enthusiastic about life, helps with that. Because the enthusiasm that you have doesn't mean that the situation may not be bad. It doesn't mean that you didn't have an argument. It doesn't mean that you still don't have to do that report. But what enthusiasm means, what enthusiasm does, it gives you a better outlook. And after all, the outlook is what helps us. Do you know, I read something recently that there are 20 million signals that come at us at any moment. And we only are able to process about 130,000 of those. So 20 million and 130,000. Where do the rest go? Well, they all become distorted. Right? So we ignore some, we drop some out, but we distort some of it. Right? And what does distortion mean? Distortion simply means that when you see a particular signal, when you see a particular situation, you hear a story, you see a video, somebody talks to you, you develop in your mind a map or a filter for what that person is telling you. That's why 2 people, 3 people, 4 people can see the same thing and come up with different interpretations, right? You have a car accident and everybody's looking exactly at the same spot. And you ask, hey, what happened? And you get 5 different stories. Because we are very much able to filter that information. And then what do we do when something else happens, right? So we've got this library of situations in our mind. And when something else happens, we just take that thing and we begin comparing, right, to the library that we have. And when we find one that's similar, okay, that's what it means. So we are able, right, then to process and to filter and to catalog things based on what is in our mind. And if we can filter something, we can determine how we feel about it. Oh, there you go. That's the key right there. So enthusiasm, excuse me, is determined by your history. And so what are some ways that you can begin developing and maintaining enthusiasm? Number 1, follow what makes you happy. Excuse me. Follow what makes you happy. Think about things you want to learn. Begin practicing and doing some things that are different. Don't keep doing the same thing. Surround yourself with people that will help you get along and go along in this direction. If you do that, you are protecting yourself and you are enjoying your life. That's our thought for today. All right. So we are back. Dr. O. We are talking with Dr. O about disparities, health disparities within the minority community. We got a little choked up there. All right. So Dr. O, so tell us, so we've got all of these disparities. What can we do and what is being done about them?
Wonderful. Great question, Dr. Woode. By the way, thank you for that thought of the day on the enthusiasm. Yes, sometimes we lose, we lose sight of what's good and just focus on the problems that we're having. A little bit of enthusiasm, a little bit of zest for life goes a long way. And what can we do? That's a very good question. Something you said earlier on before we took a break, I wanted to comment on. And that was when you said sometimes it can seem overwhelming, right? You want to throw up your hands and say, what can I do? There's nothing I can do about it. Let me come at it from a different angle. A wise person said to me a while back. I'm involved in new projects, things that we're doing to enlarge our reach, right? And this person, I was basically having the same problem. It might seem it's things do seem overwhelming, and he said, "Well, that the saying goes, how do you eat an elephant?" And he says, "One bite at a time." So, what do we do about it? We're about to eat an elephant, and the only way to proceed is one bite at a time. Forget about the whole elephant, forget about how much work there is to just take one bite and take the next bite. Or, like the old Chinese saying that a journey of a thousand miles begins with one step. So, one of the first steps we're taking on this is highlighting the problem, educating, bringing to consciousness that this is a problem that exists. Because when we recognize it, is half the solution to the problem.
Oh, I love that, love that, love that. So how and help me. How can I, as a physician, if there are doctors out there watching us right now, right? How can I, as a physician, begin moving in the direction of helping to decrease disparities within the population that I serve?
Yes, I think being self aware is always where I start. Being self aware. And by the way, one thing you said earlier on about health disparities, it's not always racial. It's not always racial. It's not always a racial bias, but there are some intrinsic biases that we all carry, right? Um, if you don't look like me, if you don't sound like me, if you're coming in for the 10th time with DKA, diabetic ketoacidosis, as a physician, I start getting frustrated at you. When are you going to get it, Dr. Wood? Get your act together, man. Or for instance, the alcoholic, right? And then my humanity starts getting in the way instead of letting my humanity stay behind and my professionalism be in front and say, okay, this patient in front of me today needs help from me. This is not the time to judge, or this is not the time to overlook. That's one thing. Just being aware, conscious of the intrinsic bias that we may have, and understanding that also, like we talked about the pulse oximetry and the EGFR, understanding that some assumptions in healthcare may not be as accurate as we think it is. When you know that, when you're aware that the person in front of you may be distrusting of the system, winning their trust is the first step in the battle. Knowing yourself as a physician to understand that, okay, ask yourself some questions. Am I overlooking some things? Am I taking some things for granted? Am I understanding context? Those things begin to help outcomes. I mean, I'm sure you're aware, but studies were done in the past where the African American patient coming into the emergency room would not get the uh, blood clot uh, blood clot busting treatment they needed for their stroke or their heart attack compared to the Caucasian patient, right? I'm looking at, I brought this up earlier on. Infant death rate in North Carolina is 2.5 times higher than in the black community than in the white community. Why is that? Sometimes, even when you solve for socioeconomic class, these differences exist. So, if you as a physician is not aware of this and begin to look out for those biases or those gaps in the system that cause care to not be equitable, then we're not going to make the impact that we want to make.
Wow, wow, wow. Well, Dr. O, thank you for being with us. I want to give a chance for you to do something for me. I want you to take a minute or two and just tell our folks where you are, how they can reach you. If someone wants to see you as a physician, how they can do that, how they can follow you, what's going on with you in social media. Why don't you take a minute and tell us about that?
You're very kind, Dr. Wood. So I'm Dr. Oriaku. Everybody calls me Dr. O. I'm the founder of Crown Clinic. We're on South Tryon Street in the south end of Charlotte, North Carolina, 4500 South Tryon. My office phone number is 704-527-5522. And you can find me on the web at crownclinicpa.com. Also, recently, I started a telemedicine platform aiming to bring world class healthcare to sub Saharan Africa. beginning with Nigeria, where I grew up. There's a lot of brain drain out of Africa, and I'm trying to reverse the best I can the brain drain by harnessing the expertise of Nigerian-born physicians or African-born physicians to help deliver care to Africa. And that is at socratesmd.com. And as if I wasn't busy enough, I've also started a YouTube channel. It's called The Minority Health Report with Dr. O. Health disparities, healthcare in minorities has always been my passion. And this is where I discuss things as they affect the minority population. Because I have a passion for minorities does not mean they're the only people I cater to, but that I feel that there needs to be a voice to speak to the unique needs in the minority population. So that the Minority Health Report with Dr. O, that's my YouTube channel, is also by the same name on Instagram. And yes, Crown Clinic is also on Instagram, and Socrates MD is also on Instagram. So we're a little busy around here.
Well, Dr. O, thank you so much for being with us. We appreciate you coming and helping us have this discussion. And I hope you will allow us to bring you back again so we can continue this conversation and have some more. So thank you for coming tonight.
Absolutely. Thanks for having me. This is not a conversation that can be dealt completely in an hour's show. By the way, I'm amazed an hour has gone by already. But absolutely, I'll be honored to be invited back because this is a passion near and dear to my heart. Thanks for having me.
All right. Thank you. Well, guys, as always, I am excited about you being here tonight and excited that we were able to have this conversation. We thank Dr. O for coming. If you have not done so, I want you to go over to his channel. If you are subscribing to me, if you're one of my followers on whatever platform, go back over there and support him. If you're in the Charlotte area and you're looking for a physician, you've got his contact information, and we'll put that in the show notes. We want him to say that his business, his platform got so much bigger because he was on our show, and that the people over at Dr. Woode, that's the subscribers and his community, are so supportive. Okay, so make sure that you go over there and make sure that you support him. If you're in the Charlotte area, once again, and you're looking for a physician, Dr. Obinna Oriaku, right, is his name, and you got all his contact information. So healthcare disparities among minorities, as you heard, right? Minority healthcare disparities, it's not just based on discrimination. It can be socioeconomic, it can be cultural, it can be based on language barriers, it could be based on skewed data that comes from studies that we have where minorities are not accurately or are adequately represented. So there are so many different things that can cause disparities. And my challenge to you is that you become aware. If you're out there, if you are in a community where the culture says that you don't ask questions, you got to get past that. You have to be able to talk with your physician, get someone to go with you. If you are having difficulty with the language, wherever your language is, if it's English, or if your physician is English or speaks English, or he speaks another language, get someone that can go with you to help translate. If you are struggling with finding a healthcare provider, okay, don't struggle alone. Get together with family, ask around in your communities, in your churches, in your social circles. Find out who the physician is that you can go to. And then if you are seeing a physician, ask them whether there is a translation available. Okay? Ask them if there's a translation available. One of the things that I love to have happen is I love for patients to bring with them foods that they eat so that we can sit down and talk about what this food would represent in their meal. Right? There's so many things that we can do, and that's my challenge to you. Don't just accept what's being given if you think there's something wrong. Talk to your doctors and let them know, hey, I don't understand. I need a little bit more information. We love to teach. That's what we do, and that's what we do here on the channel. If you've not already done so, go ahead and subscribe to our channel. Share this video with your family and friends, and then come back next week for our next video. Here on our channel, I'm Dr. Dwayne Woode. That's Woode with an E. We help to educate. We help to empower. We help to encourage you to take charge of your life and your health. Avoid complications, go to the next level, and get that life that you've always wanted. Let's get out of here, and we'll see you next week. Let's get some music.